All right. Hi, everyone. I know all of you have been here before for Journal Club. I'm Jess, our other host here, Nick Maxwell, and today we have Dr. Kamoga Dixon, who is going to be leading the session. Dixon is a third-year resident at Makerere University, as all of you know, and we are super thankful for him offering his time and expertise today. I think this is a great idea to kind of rotate presenters each month. And so if you guys ever want to run a session, Jimmy or Godwin or Moses, if anyone's interested, please just reach out and let us know. I think this is awesome to hear different voices, different perspectives. And then if you guys have questions, comments, anything at all, just feel free to chime in or write in the chat and we'll be monitoring there. And without any further delays, we'll go ahead and get started. Dixon, take it away.
All right. Good evening, everyone, and good morning on your end, Jess. You're welcome to this presentation. I'm going to be talking to you about shoulder dislocations. I'm going to focus on the ED approaches. Dixon Kamoga, like Jess introduced me, I'm a third-year resident of emergency medicine at Makerere University, and I'm glad to be delivering this presentation today. So I have no disclosures. This is going to be my outline. I'm briefly going to take us through the anatomy of the shoulder joint, and briefly go into the epidemiology of shoulder dislocations. I'll tackle the different techniques of shoulder dislocation reductions. And I think at the end of the presentation, all of us will have developed an approach on how to manage these shoulder dislocations within the emergency departments. And then I'll briefly just talk about the dislocation, disposition for these patients, and then give some concluding remarks. So briefly about the anatomy, the shoulder joint is really one of the most mobile joints in the body, comprised of 3 bones and 4 joints, and it's probably one of the most dislocated joints in the body. It has quite a range of motions going at about 180 degrees all the way around. And so that makes it very prone to dislocations. So the 3 bones that form this joint are the clavicle, the humerus, and the scapula, as you already know. And this is actually very clearly shown in this picture right here. So we have the joints that form the shoulder joint. So majorly what we put focus on when we're describing shoulder joint dislocations is this joint that's painted purple right here. So you have the humerus right here, which articulates with the scapula, and then dislocations can go in either way if the humerus falls out of position. So epidemiology-wise, shoulder dislocations are quite common emergency, and on a global scale, they happen in about 21 to 51 per 1,000 population. So this is global data. It doesn't really represent, it may not really represent what happens in the local setting because there's really limited data that highlights these incidences. So most of this data is on a global scale, but as you can see, it's quite a common emergency that anyone can experience on that shift in the emergency department. So about 20% of the patients that will present with dislocations in the emergency departments will be recurrences, meaning that out of those 100 patients that you're going to manage, about 20% of them will be experiencing a dislocation for the second time. Also, there's evidence that if you attempt to reduce these dislocations in the ED for the first time and you fail, then that increases the risk of a second reduction failure. So meaning that you have to have a well-systemized approach, systemic approach for managing shoulder dislocations, because if you just approach it anyhow and you fail on your first attempt, then the muscles that surround the shoulder joint could go into spasms, and that could increase the risk of failing on your second attempt. There are typically 3 shoulder dislocations that we talk about, and that's the anterior, posterior, and the inferior ones. About 95%, 97% of them are anterior, and this is very easy to remember because the anterior aspect of the body is the one that you commonly see. Almost all the shoulder dislocations that will come to you will be anterior. So how you remember that is that anterior is the part of the body that you see first, and then most dislocations are going to happen in the anterior aspect. Rarely, they happen posteriorly, and that's in less than 3%, and then the inferior ones are really much rare, and they happen in less than 1% of patients. So typically, we want to reduce every shoulder dislocation after obtaining an imaging. However, there are situations where reduction could come before you do an imaging. And that's in patients who could have neurovascular compromise, because the longer you wait to reduce it, the risk of worsening the injury. So if a patient comes to you, you're thinking they're having a dislocation and you don't feel distal pulses, just go ahead and attempt to reduce the dislocation before you transfer the patient for imaging, because the longer they stay with the dislocation, the worse the neurovascular injury, gets. So yeah, that's one of the situations. Typically, the only situation where you want to reduce the dislocation before getting imaging. So, like I said, anterior dislocations are the most common, so I'll talk about them first. The typical mechanisms, usually patient falling onto an outstretched hand, maybe they were on top of a tree or they were in a car and they got ejected out and they fell onto their arm with the hand stretched. So that could easily put a backward force onto the shoulder and causes the humerus to pop out of position. And then the other mechanism is if you get a direct blow onto the shoulder from the anterior end, that could push the shoulder joint out of position, causing the humerus to lie anteriorly. So it's those two mechanisms that typically cause shoulder dislocations. All right, so when a patient comes to you, you want to have some clinical signs that you're going to elicit in them for you to suspect a shoulder dislocation that's anterior. So this image on the right just briefly shows us how patients might walk into an emergency department with shoulder dislocations. So what we see, now one of the things that are going to stand out to you is that there'll be an obvious deformity on that affected shoulder. And some of the deformities are this: the acromion will appear bulging on this side, and when you palpate the patient laterally, you feel it almost popping out. And then the shoulder will appear shredded off in a way that it's almost falling off the body, as you can see. So this is the normal one on the left, but then as you can see, the right, and then as you can see the right, the shoulder is almost falling off. So that's what we describe as being shredded off. And then, of course, because there's edema, inflammation, and then the humeral head is also kind of popped out anteriorly, so it will be bulging into the deltopectoral groove, and instead of having a nice depression, as we see here on the normal side, it will appear bulged because there's probably inflammation and edema going on, and then as well as the humeral head lying anteriorly in this position. And then obviously there will be limited range of motion on this affected side. So when you ask the patient to move this hand, they probably won't do it because they're in so much discomfort. There are some classical signs that we can list. They're not very diagnostic, but they could help you suspect that the patient has a shoulder dislocation. And they're quite obvious. One of them is the DAG sign, where if you ask a patient to touch the contralateral normal shoulder, they can't do it. It's obvious because the joint on this side is dislocated, so they cannot move the shoulder across their body to touch the opposite on normal shoulder. So that's what's called a DAG sign. And then the next sign that we can list is the Carlowitz sign, which is just by, just looking at the shoulder. This side will be appearing kind of increased in girth because of edema and the humeral head falling out of position. So this side will appear increased in girth compared to the normal one. So how do we definitively diagnose these things? So when a patient comes to you, these are bones, so you're definitely going to need imaging. And typically we want shoulder views. There are 3 standard views that we obtain for shoulder dislocation. That's the AP, the scapular Y view, and the axillary. Each of them has advantages, but the classical imaging view that we want to obtain is the scapular Y view because it's really more sensitive for diagnosing shoulder dislocations. And we're going to see in the subsequent images how this will appear on the X-ray. The AP view is really good. However, its diagnostic value is a bit of low compared to the scapular wide view. So the standard view for shoulder dislocation is the scapular wide view or the transscapular view. And so meaning that if a patient comes to you, you're suspecting a shoulder dislocation, when you're ordering for imaging, just be very specific, order for the scapular wide view because it's very highly diagnostic, as we're going to see. The axillary view might really just be obtained or ordered for if for any reason you can't obtain the true AP view or the scapular wide view. And it's really very hard to obtain because it requires that the patient's hand is kind of abducted away from the body and the beam is directed inferiorly into the axilla. So really, it's, you can only get it if for any reason you can't obtain the first two views, which is the AP and the scapular wide view. So this is what a scapular wide view looks like, and this is a normal one. So meaning if they took a scapular wide view of you and me here, this is how it's going to look like. So this view is not a true lateral view of the shoulder, but rather an anterolateral view. And as you can see, the beam is kind of directed from this angle and towards the shoulder. As you can see how this arrow is moving. So from down, going all the way up to the scapula. And then, so if it were a true lateral view, the beam would come from this direction towards the shoulder. So it's kind of an anterolateral view. But I'm sure, I'm sure imaging specialists know how to obtain these views. So for you as you're ordering, just put that you need a scapular wide view for a patient that you suspect to be having a shoulder dislocation. So just to briefly walk you through what these things are. So what we're looking at here, this is a clavicle, obviously. You know, the clavicle articulates with the acromion, which is this part of the scapula, and then there's a coracoid process which moves posteriorly, and then inferiorly you see this thing that's projecting all the way down. This is the body of the scapula, so it's forming into a shape of a Y, as you can see. So this is one limb of the Y, that's the next one, and then this is a downward projection of the Y. So in a normal scapular Y view, you have the humeral head sitting into the two arms of the Y, which is what we call a normal view. So this is the humeral head, and this is the shaft of the femur. As you can see, it's almost sitting into the two arms of the Y. So that's the normal scapular Y view. And then in the abnormal one is this image that we're looking at on the right. So this is the same view as we saw in the previous image. So this is the clavicle that you can see running horizontally here. It's articulating with the acromion. And then posteriorly, we have the coracoid process. And then this is the body of the scapula. So again, this is an anterolateral view. So you have the beam of X-rays running in this direction towards the shoulder. So as you can see, at this point, we don't have the humeral head. So it's dislocated, and see where it's falling. It's here lying anterior to the anterior arm of the Y of the scapula. So this is the Y. Once again, it's coming like this, and then all the way down. So if it were normal, we'd expect the humeral head to be lying in this position, but you see where it's lying. It's anterior to the Y, right? So that makes it an anterior dislocation. And so as we're going to see subsequently for the posterior dislocation, it will be falling here, which is posterior to the Y. Then, so the AP view is really, like I said, not as diagnostic as the scapular Y view, and as you can see, so the beam is directed from the anterior end posteriorly towards the patient. So you have the scapula, the clavicle, you have the acromioclavicular joint here. This would be the glenoid fossa where the humeral head sits, but as you can see, it's dislocated anteriorly. It's lying anterior to the glenoid fossa. So that's an anterior dislocation. So you can see it doesn't appear as nice as a scapular Y view. So for that next patient that you're going to receive and you think they're having a shoulder dislocation, order for a scapular Y view. So how do we manage anterior dislocations? There's very many described techniques in literature. This particular paper that I used to prepare for this presentation described 26 different techniques. However, for this presentation, I'm going to just take you through. And again, the goal is for you to develop a systematic approach for managing shoulder dislocations for patients that could walk into the ED. So you don't need to memorize all these 26 techniques, but rather develop an approach where you're going to use one or two. Again, the second one, you could just use it if the first one fails to reduce the dislocation. So there are many, but again, you need only a few that are going to help you when you're managing your patients. So there are well-studied advantages and disadvantages of the different techniques. However, there's no good data that's comparing the efficacy of the different one. So that's why it's important that you just develop your own, approach using one or two of these techniques. So you don't need to memorize all of them because there's not even good data that has reported that one technique is better than the other. So whichever technique you're choosing to use, have a reason to use it, know how to use it, and have a reproducible pattern in which you're going to use it for your next patient that comes to the emergency department. Generally, their effectiveness falls between 60 to 100%, meaning that any technique that you're going to use could have almost 100% chances of reducing a shoulder dislocation. So for this talk, I chose the ones that are having very good effectiveness for reducing shoulder dislocations. So meaning that after this presentation, even if you just choose to take the ones that I'm going to take you through, it's going to be good enough for your next patients that you're managing the EDs. So how do you prepare our patients for reduction? Again, the general principles apply. Counsel the patient, consent them. You're probably going to need another clinician who's going to help you, maybe doing some countertractions or administering drugs if you have to. And then you have to make your patients comfortable for this procedure because, they're coming in with a lot of pain and you're going to inflict more pain by trying to reduce the dislocations. So have your team set up, have your drugs ready, be ready to provide a bit of procedure sedation with maybe any of the drugs that you could be having. There's no preference for which general sedative that you're going to use. You could use ketamine, you could use propofol, you could use midazolam, depending on what's available. There's some little evidence that recommends that you combining local anesthesia to light sedation could result into higher chances of successful reduction. So meaning that a combination of the two modes of anesthesia could be more beneficial in ensuring that you're reducing the dislocations effectively. So muscle relaxants, there's not so much good evidence on their use. What's really recommended is that if a dislocation has stayed for long, there could probably be a bit of muscle spasms, so you might need to give them a muscle relaxant to try and take that away. Or if you fail on the first attempt of reduction, then you could consider giving them a muscle relaxant because the manipulation that you did in the first attempt could elicit some muscle spasms and make your next attempt very difficult. So I don't know if anyone knows how we provide local anesthesia for shoulder dislocation. Because the shoulder joint is very big. So where are you going to inject the local anesthetic? I don't know if anyone knows, they could just type it in the chat or they could just put up their hand and tell us what it is. All right, so what's recommended is that you could just, inject it into the glenoid fossa itself. So you could just draw about 20 cc's of selignocane, bupivacaine, and you inject it into the joint. Into the glenoid fossa. So first, like I said, there are over 30 techniques that are described for reducing shoulder dislocations. I'll just focus on this as my first approach because it's what most EDs use. It's really effective. It's reliable. It's safe. It can be implemented by just one clinician. So it's called the FAIRS technique, and it draws its name from these three words: fast, reliable, and safe. So meaning it can be implemented in the EDs and it's going to effectively reduce the dislocations. There are essentially four maneuvers that we go through when implementing the FAIRS technique, and that's the traction, oscillation, abduction, and external reduction. And the external rotation. I abbreviated them as to the A and E, so meaning that if you use this acronym, this mnemonic, you probably remember it anytime that you're working on a patient who could have a shoulder dislocation. So the T in this mnemonic is the traction. So you're going to apply a traction where you're just basically pulling the arm away from the patient, from the trunk rather, and then you're doing oscillations up and down. As you're maintaining traction, then you're abducting the hand. You're going to see it in the subsequent images. I know it could be very difficult to follow when it's just words like this. And then finally, once the arm is abducted to almost 90 degrees, you do external rotation. So this is what we're looking at in these images. So in image 1, this red arrow is pointing at the first maneuver, which is tracting the hand away from the trunk. The second image is showing the back and forth oscillatory movements, which is this black arrow showing that you're moving the hand up and down, and then you're tracting, and then you're abducting it away from the body in your third maneuver, which is showed by this red arrow. So this is abduction away from the body. And then the last maneuver is actually external rotation, which you're basically just going to twist the hand externally at the level of the shoulder. So you just kind of use these hands that you're seeing here to twist it externally. So these four maneuvers are almost always effective in trying to reduce the shoulder dislocation. So this image on the right just basically tells us the same thing. Like I said, the mnemonic is to the A and E. So first maneuver is traction, where you're just pulling the hand away from the body. Then the next one is O, which is oscillatory movements, where you're just basically moving the hand up and down in the anterior and posterior directions. And then the third maneuver is the abduction, where you're just basically moving the hand away from the trunk towards this direction. And then at 90 degrees, which is at about this level, you externally rotate it. They almost always fall back into position. There's a video here. I'm not quite sure if it will play, but if it doesn't, then you'll probably watch it on your own when I share the slides.
Dixon, I'm going to interject you right there. A few minutes ago, you mentioned a great idea of injecting anesthetic directly into the shoulder joint. I'd love to hear from people on the chat, or if they want to chime in out loud. Do they usually sedate people for putting in shoulders, or do they do local anesthesia directly into the shoulder joint? I'd love to hear from the audience on that one, because these are painful techniques and most people can't tolerate them without some sort of pain control.
Yeah. I don't know, as maybe people think through the answers, I could just be. Oh, yeah.
Yes.
Someone.
This Jimmy?
Yes, Jimmy.
Yeah, I think I've had like about 3 shoulder dislocation reduction last year, and I've basically used a light sedation for all of them, a combination of ketamine and propofol to achieve the light sedation and be able to reduce the dislocation using the FAIRS technique.
All right. Yeah, so that's what Jimmy does. Again, like I said, light sedation alone could just be enough for any patient. It's just a few studies that have shown that you could combine if the light sedation is not good enough, but it's almost always good enough to get the patient comfortable and you reduce the dislocation. But if you have to consider using local anesthetic, then you have to inject it into the glenoid fossa. I don't know, is your practice different, Jess? What do you do usually to get these patients comfortable?
Great question. I will say there is an interesting culture here in the US of what's called shared decision making, meaning that patients want to feel like they made the decisions for their own medical care. And so I'll usually offer direct injection of local anesthetic into the glenohumeral joint, or I'll offer sedation. And I haven't had anyone take me up on the local anesthetic yet. They all want to be put to sleep for me to put their shoulder back in. And some of that is people who've had multiple dislocations, know how painful an experience it was, and they have some traumatic memories around it. They just want to be put out, so to speak. Nick, I'm curious, and Deb as well, because you're both on the call. Have you had different experiences here?
I tend to be a similar approach where one of my first steps, especially with shoulder dislocations, because as Dixon mentioned, a lot of times people have done this multiple times. And so, if they say, yeah, this has happened like 3 different times, usually they just like inject some lidocaine and pop it back in. I say, okay, we'll give that a shot. I am rarely ever opposed to the lidocaine injection because it's usually well tolerated. I think it's really safe. And I think one of the things I have an increasing appreciation for in emergency medicine is not just did we succeed, but how well did we succeed? So, like I can get your shoulder back in almost guaranteed. If I like put you out, like if I give you sedation, but that doesn't mean lidocaine won't make it a more comfortable process because when you wake up, like your shoulder might still hurt. And so I'm not opposed to both, but I do tend to do a lot of shared decision making, but I almost always put people out. There's only a few situations in which I don't.
Jess, I just want to qualify to everyone here that I'm Deb Stoner. I work with Jess and Nick at Techies, and I am an emergency physician, but I have been retired for several years. I, like you, Nick, always completely sedated patients, explained the procedure. That's how we were going to proceed. Nobody ever, objected to that. However, later in my career, I became a great fan of the Cunningham technique, which does take more time. So, but giving the patient a choice between at least 2 different ways to approach it, I found later in my career, more and more people wanted to just get out of the emergency room. So not having any sedation or having a local injection like you described, they were very happy with that. But I did have pretty good success with the Cunningham technique. But again, it takes time to sit there with them and massage and get them. And you have to have the patient who is amenable to participating.
Oh, all right. Looks like we all have we all have kind of similar practice. Yeah, but the difference is that patients don't really make a choice on what mode of anesthesia to use. So usually we choose we think is going to work for them and we'll go for that. But again, most of us are comfortable just having them lightly sedated and we reduce it. So I have this 3-minute video just kind of showing how the first technique is done. I don't know if you're seeing my screen, Jess. You could just help me confirm that.
I can't see it. I see the PowerPoint.
You had an episode of passing out,
Yeah, I
and
can't see,
after your shoulder was hurting,
can't
right?
see the video.
and we
You can't
found
see it.
on entry that it looks like
We can't see the video. We can hear him talking. I
think
can try sharing from mine, Dixon, and see if that works. Give me 1 second.
Yeah, I
I
think
don't know if you could play it at the end.
sure.
Yeah, we could just play it at the end. We can move forward for now and then come back to it. I'll see if I can get it up on my screen.
I agree. Okay, so let's proceed. So why is this technique good? It has about 85 to 100% success rates. There are no reported complications following it. Can be performed by a single clinician, as you've seen in the images. One clinician could just do all the different maneuvers. And then it's fast, almost always easy to implement in the EDs. And the very, I think, good thing about it is that it's also effective for posterior dislocations. So if you're not sure where the dislocation is, you've not been able to obtain imaging for the patient, this is a maneuver that you can implement because it's going to be effective for even posterior dislocations. And there's there's probably no limitations to it. Any patient can really have a FAIRS procedure done for them. Then the other techniques, like I said, this one is the traction, counter-traction. I chose it also because its success rates are pretty high. As you can see, it's 91 to 100%. And it's easy to implement with really very limited resources. What you need is a pair of hands giving you counter traction and then yourself pulling it towards yourself. So this could actually be the person that's doing the counter traction could even be an attendant. It doesn't necessarily have to be a clinician. So, and as you can see, you're applying a traction towards yourself and away from the trunk of the patient. And then you wrap a sheet around the mid-chest just to provide counter traction to the force that you're using to pull anteriorly. Without any further movements or maneuvers, this almost always causes the shoulder dislocation. The humerus to fall into the glenoid fossa, which is its natural position. You could augment this maneuver by putting a third traction, which is this that we see in this second image, where you're just pulling the hand, abducting the hand away from the body. So you're tracting, which is this first arrow, and then you see, so in this image, it's probably an attendant who is doing the counter traction. So they're helping you put the counter traction to the patient, and then you're doing an abduction, you're applying an abduction force to the humerus. So this is also almost always effective in reducing shoulder dislocations. So there's another technique, which is the axial traction with acromial fixation. I chose this also because it's easy and it's almost always effective as well. And it can be implemented by a single clinician. So what you're basically doing, you're holding the hand, the affected hand at the wrist, and you're tracting it away from the trunk, as you can see with this first force. And then you're just basically using your less dominant hand to stabilize the acromion and pushing the acromion into, the humerus into position. So this actually is reported to have 100% success rate. So it's quite effective, and you need only 2 movements to move the dislocated humerus. So these are other techniques that you can implement. I've just highlighted the names here. I'm not going to describe each and every one of them, how they're done, but it's important that you know that they're existing, and if you read through them, maybe you choose which one is going to be your personal favorite. But I feel the first technique should be what everyone should know, because as you've seen, it's effective, you need 1 clinician, and it's also effective for posterior dislocations. So meaning it's a very good technique. So how do we care for patients post-reduction? Again, there's risk of re-reduction. So you need to immobilize the hand, the limb very early. So have it in neutral position, put a sling around it or a brace. And the duration for which that brace should stay on is really variable, and it's dependent on how old the patient is. The standard time is about 1 to 2 weeks. So if a patient is older than 40 years, usually the risk of them having a frozen joint goes higher with age. So for patients that are older than 40 years, it's recommended that you do their immobilization for a much lower duration of time. For a reason being, if they stay immobilized for long, the joint could become fibrous and it loses its ability to move. So have them immobilized very early. Immobilize them for a short time and have them start range of motions early. So immediately post-reduction, you have to check, obviously, the distal pulses, the sensory innervation, because you want to be sure that there's no damage that you've inflicted onto the blood vessels and on the neurons. So you have to do a quick clinical examination of the hand, look for pulses, and then sensations distally, and just make sure that those are fine. Doing a check X-ray would just be really confirm that the reduction has been effective, but almost always, after reduction, you would know that the humerus has fallen back into position, so you probably won't need to do any further imaging at this point. But if you ain't sure about your reduction, then you could obtain a check X-ray just to confirm that the humerus is back into position. So pain control, obviously, because they're in pain. And then early physiotherapy is recommended because the risk of getting the joint fibrous and frozen is really high. So get them mobile and moving very early. So early referral for physiotherapy is recommended immediately after discharge. Posterior dislocations, like I said, they're very rare, they're quite rare. They happen in about 3% of all dislocations. They tend to be quite underdiagnosed because patients could, tolerate the pain, and they may probably not present immediately to the emergency departments because of the pain. How they happen is a patient might fall onto an outstretched hand with the hand internally rotated. And then they could also happen in patients that are involved in high impact trauma or seizures. So I believe this is very important because most clinicians wouldn't suspect that a patient who has just had a seizure activity can get a shoulder dislocation. But because of the jerky movement and the decorticating that happens during a seizure activity, the humerus could fall out of position and gets dislocated posteriorly. So this is how patients with a posterior dislocation would typically come to you. They'll have the hand abducted slightly off the body and internally rotated. And then there'll obviously be very limited range of motion because there's so much pain on that side of the body. So they won't be able to move the shoulder joint. Imaging techniques are really the same as for anterior dislocations, and we essentially want to obtain the AP view and the scapular Y views, and we can obtain an axillary view in case we can't obtain these first two views because they're really diagnostic, and if you can have them, then they should be your go-to imaging views before you think of anything else. So there are some slight differences on how these images look like. If it's a posterior dislocation, the AP view gives what is classically described as a light bulb sign. I'm not sure it actually looks like a light bulb, but that's how people describe it. So what you can see here on the left shoulder joint is that this is the glenoid fossa where ideally the humerus should be sitting. But as you can see, it's kind of rotated out and the humeral head is facing posteriorly. So this part would ideally be on the lateral aspect if you're to image this image. I mean this shoulder joint in a normal patient, but as you can see, the humeral head is rotated out of its glenoid fossa, which is this, and it's facing posteriorly. So this gives the humerus a shape of a light bulb, as you can see. So yeah, people think this looks like a light bulb. I'm not quite sure it does. So it's a posterior dislocation if you see something that looks like this, and it's described as a light bulb sign. Then in the scapular Y view, again, this is a normal one. You have the two arms of the Y and then the scapula, the body of the scapula. So like I said, if it were anterior, it would be lying anterior to the Y. And then if it were posterior, it would be lying posterior to the two arms of the Y. So in this view, which is the abnormal scapular Y view, we're looking at the clavicle up here. Oh, sorry about that. And then we're looking at acromion, which is this that articulates with the clavicle, and then the coracoid process of the clavicle, and then the body of the, the coracoid process of the scapula, and then the body of the scapula projecting down. So as you can see, in normal situations, this thing should be lying up here into the two arms of the Y, but it's moved out and it's lying posterior to the two arms of the Y, right? So it's a posterior dislocation because it's lying posterior to the two arms of the Y. So there are other images that we can do, but really these are to rule out any soft tissue injuries, and these are, of course, the CT scan and the MRI. And if you only obtain these if you're suspecting that there's a neurovascular injury or any other soft injuries. Ultrasound is really a very diagnostic field in shoulder dislocations. You can only obtain it if for any reason, maybe a patient is unstable or you don't want to expose them to radiation for any reason. You can consider doing a shoulder ultrasound if for any reason you cannot obtain the CT and MRI for these patients. So Again, remember the first technique can reduce the posterior dislocations as well. However, there are some dedicated techniques that are just specific for the posterior dislocations. And one of them is this Wilson's technique, and it's the only technique that I'm going to talk about in this presentation. So I want to draw your attention to this image on the right. And as you can see, there are two clinicians. I want you to focus on where these arrows are pointing. This first clinician has just moved the hand, abducted it rather across the body. As you can see, this is the affected hand. They've abducted it across the body, and they're making the patient to touch the contralateral normal shoulder. So the first movement that they're applying to this affected shoulder is a downward traction, which you're seeing in this arrow at the level of the elbow joint. So this first clinician, after abducting the hand across the chest, they're applying a downward traction at the level of the wrist. And the reason for doing this is to try to kind of disimpact the humeral head of the acetabular ring. So remember, it's dislocated posteriorly, so they're pulling it downwards so that it gets disimpacted off the glenoid rim where it could be touched. And then this second clinician, after pulling it away from the glenoid rim, remember it was in posterior position, so they're just kind of just manipulating it back into the anterior position so that it falls into the acetabular rim. I mean, into the acetabulum or the glenoid fossa. So again, they're just they're basically three movements here. The first movement is abducting the hand across the body. Then you apply a downward traction just to disimpact the humerus or humeral head of the acetabular rim, and then apply a gentle posterior force anteriorly so that you move the humerus from the posterior position back into the glenoid fossa, which you're seeing this second arrow pointing at. So it's basically those three movements: abduction across the body, gentle downward traction just to disimpact the humeral head of the glenoid rim, and then a gentle posterior force that's pushing the humerus from the posterior position back into the glenoid fossa. So that's called the Wilson's technique. Again, if you don't remember this, you could attempt the Fairs technique.
Dixon, I think this is a great time to share the Fairs technique video, if that's okay with you, since it'll stick in everyone's mind that you can use this for both anterior and posterior. Do you mind if I share that now?
No, I don't. So do I need to take this down?
Nope, you are all good. I can just switch right over. I can toggle my screen. And let me know if you guys can't hear. Can you hear it?
I can't on my end, and I can't hear it. I can't see it as well.
Okay. I think it's fine if you can't hear it. It's more about watching what they're doing with the Fairs. So I'll skip ahead to when they actually start manipulating her.
I will say, like I mentioned in the chat, the couple times I've done this, because I like a couple other techniques, like usually what happens is my other techniques haven't quite worked, and my attending will go, how about we try the oscillatory method? And it's much less gratifying, where you oftentimes don't feel a nice pop back in. And you're kind of messing with it a bunch, and then you look at it and you're like, I think it's back in. But
yeah, you don't get that nice clunk the same way that you might with the external rotation method or the traction countertraction. But it's kind of like you're easing the patient into it. So if they're only lightly sedated, sometimes they can tolerate this a little bit better because it's not a sudden movement. It's like, oh, we're just going to start moving and boop, then it's back in. I've had pretty good luck with this one, and you can see that they're palpating now to make sure that it's back in place. And you can kind of combine this with scapular manipulation as well, meaning you can have one hand behind the patient that's massaging the scapula and also pulling it inferiorly while you're doing that oscillatory movement. So you can kind of combine methods if you, feel so inclined. I'm going to stop sharing my screen, Dixon. I'll let you join or reshare yours.
The other reason I kind of like it from that perspective is I think one of the things that's really underestimated until you've done a bunch of these is a lot of the driver of success is the muscles around the shoulder, right? So a lot of times you have to tire the shoulder muscles out. It's not like a big yank. Like a lot of times the shoulder is too strong to do that. And so that's why you'll see techniques where you have them like hold a weight for a while or things like that. But the nice part about the counter traction traction technique, or this method, is you can use your body weight to kind of lean back and kind of slowly tire it out. Whereas like the hennepin technique and stuff like that, it's easy for you to get tired out.
Oh, all right. Thank you for those additions. Though, Jess, we didn't see your video, so we probably play it at the end of my presentation again. We didn't see
It didn't show up on you guys couldn't see it.
I could see it.
Oh,
Oh.
I think it's probably because I was sharing. I don't know, but
Oh, sorry, Dixon. I think everyone else was able to see it.
oh,
Whoops.
that's okay. I have it. I have it in the presentation, so I watched it.
All right, you can continue.
All right. So finally, I'm going to talk about inferior dislocations. These are quite rare. They occur in less than 1%. The only data that's published about them is in case reports because they're rare. There's not any EDs there that manage quite a couple of them. So for managing these dislocations, there are also more than one techniques that could be applied. I chose this one again, the traction counter-traction, because it's easy again to implement. And as you can see, you just need sheets applied onto the patient and just pulling and counter-tracting in the opposite direction. So remember, when it's dislocated, the humerus is lying inferior to the glenoid fossa, right? So what you need to do is to, first of all, pull it upwards, which is this first arrow that you're seeing pointing up. So that's the first force that you apply onto the affected limb. Yes, again, this is the ideal position for the patient. They need to be supine and then made as comfortable as possible. So you need a counter traction, which is this force that you're seeing directed inferiorly and opposite to the first force that you applied. And this could be achieved by applying a bed sheet around the patient's neck and someone just pulling pulling away from the patient in an opposite direction. So this is just applying a counter force to the first force that's moving. So remember, the humerus is lying inferior to the glenoid fossa. You need a third person who's just going to gently manipulate it back into position. So this hand that you're seeing here is just sort of moving the humeral head from the anterior position and pushing it upwards back into the glenoid fossa. So first of all, you need to move it up because remember it's dislocated inferiorly. Because you're applying a force, the patient could move with your force. You need a counter force, which is the second arrow. And then you need a third hand that's just gently manipulating the humerus back into position. So this is just a counter traction technique, and the case reports that have been reported about it, reporting a very good outcome with this technique. So it's almost always effective for inferior dislocations. I don't think anyone has made any of these because they're quite rare. So after managing these patients, we need to send them to other areas where they're going to receive treatment. So typically for patients who are having uncomplicated dislocations, they're non-recurrences, after successfully reducing them, you're going to refer them for an orthopedic follow-up, which typically should be within 1 or 2 weeks. And then early physiotherapy review, because you don't want them immobilized for long, could get their joints frozen. So if it was uncomplicated, patient is having it for the first time, you reduced it on the first attempt. After successful reduction, you could allow the patient home, have them followed up by orthopedics within 1 or 2 weeks, and then encourage early physiotherapy, which should also be done by a physiotherapist. And that typically should be exactly when the immobilizer is coming off. So when the brace is applied for say 1 week or 3 weeks, at the time when the brace is coming off, they should be starting physiotherapy there and then. So for complicated ones, meaning they could be associated fractures or they could have neurovascular injury, or they could be recurrent dislocations. These are patients that typically need to be admitted and seen by orthopedics before they're allowed home. So after a successful reduction, if it's a recurrent dislocation, have them followed up by orthopedics before you allow them home. And if you're suspecting any soft tissue injuries, like I said, you need to do CTs and MRI because you need to look at what soft tissues could be injured. So what are my takeaways? With over described 30 techniques for shoulder dislocations, every clinician needs to have kind of a systematic approach of how they're approaching shoulder dislocations. So meaning that you need to have 1, 2, or 3 techniques that you need to employ for every patient who could have a shoulder dislocation. And if your first attempt probably doesn't reduce the dislocation, you could employ the next one. If the next one doesn't, then you could employ the third one, but you don't need to memorize all the 30 of them. So just have an approach that you could reproduce on every shift, and for that next patient who could have a shoulder dislocation. So again, I've been emphasizing this in my almost all throughout this presentation. The first technique is a good place to start. It's very effective, can be implemented by one person, has almost 100% effectiveness, and it's effective for both anterior and posterior dislocations. So if you ain't sure about other techniques, at least remember the first technique, because it could be the game changer for that patient that could have a shoulder dislocation. Again, about 70%, 97% of the dislocations anterior. So maybe if you're unable to obtain imaging for any reason, think it's anterior until proven otherwise. Do not forget to give analgesia. We've described the different modalities of anesthesia that you can give the patient before you reduce the dislocation. Again, it depends on your practice and your patient preferences. So if a patient prefers local anesthesia, if a patient prefers to be knocked out completely, then you could consider giving them general anesthesia. Early immobilization is early range of motion, meaning that after immobilizing, allow the patient to start moving the hand, the upper limb very early, because that's very effective in promoting healing. So after the 1 or 3 weeks of immobilization, have them to start limited range of motions. Some people actually recommend that you start them before you take off the immobilizing. Before you take off the immobilizer or the brace. So have them start to do gentle, limited range of motions, even when they're still within the immobilizer, because that promotes effective healing and it prevents formation of fibrosis within the joint. For all fractures that are dislocated, for all dislocations that are associated with fractures or recurrent ones, have them seen by an orthopedic surgeon before you send them home. I guess this summarizes my presentation. If there are any comments or any questions, you could ask them at this point. Thank you for listening, and I think I'll hand you over back to Jess.
Dixon, thank you so much. We appreciate such thorough preparation, and you had great images on our slides. People always request more pictures. So some of these techniques are hard to visualize, and I do suggest that people take a look at the article we sent out in WhatsApp. If you have questions about the techniques, you can always go on YouTube and look at how they're performed in real time. But I agree with Dixon, having a handful of techniques in your pocket that kind of work for you and that you feel comfortable performing and that have been successful is really key. And I love his point about checking the neurovascular status after you put that shoulder back in. You always need to make sure that this person still has pulses, good cap refill, that they can wiggle their fingers and that kind of thing. I put the survey link in the chat again. If anyone has feedback, comments, suggestions for future sessions, please do fill that out so we know. And if anyone ever wants to present at future sessions, feel free to message Nick or I directly on WhatsApp. Dixon, we so appreciate you taking the time to do this today. It's awesome to hear different voices and perspectives. And thank you everyone for being here. We're looking forward to seeing you next month.
All right. Thank you, Jess.
Thanks, guys.